Around. So LVADs are left ventricular assist devices. So these are devices that are placed into a patient's heart to help pump blood around that patient's body. Right? Left ventricular assist devices. We'll get into the anatomy with some graphics down below, but the left ventricle is the part of the heart that pumps blood to the rest of the body, right? The brain, the arms, the legs, the intestines, the kidneys, the liver, all that good stuff. The left ventricle pumps blood there. So this is a left ventricle assist device, aka a device, a machine meant to assist the left ventricle in pumping blood to the rest of the body. This was birthed for those who have heart failure. Many are probably familiar with what heart failure is. It affects a lot of people, 6.5 million people worldwide, or I should say in the USA. Worldwide, it's more than 4 times that, or right around that, 25 million people worldwide. And of those individuals with heart failure, up to 5% will progress to end-stage heart failure. And that's despite medical management, right? There's a lot of medications that patients with heart failure take. Some of you watching this video may have heart failure or treat patients with heart failure and see these patients or take these medications. Things like beta blockers, things like ACE inhibitors or angiotensin receptor blockers. We're kind of getting into these other medications like empagliflozin, et cetera, et cetera. And those medications are effective, right? If you have heart failure, those medications do work. They do improve outcomes. But despite that, there's still a percent of patients, up to 5%, that will progress to end-stage heart failure despite taking all those medications. And really at that point, you have very limited options, right? The cure would be heart transplant. But there's patients who don't qualify for heart transplant. There's some patients that don't want a heart transplant. And even of those who do want a heart transplant and do qualify, there's not enough hearts to go around, right? Because unfortunately, to get a heart, someone has to donate a heart, right? So there's lots of patients with end-stage heart failure who either are waiting for a transplant, don't qualify for a transplant, or don't want a transplant, who may benefit from a left ventricular assist device. In fact, when they look at the numbers, what they have found is that there's been a huge decrease in mortality, all right, and that's death. All right, when they first started studying LVADs, the 2-year mortality for those on medical management was about survival was about 5%, something like 5 to 10% at 2 years for end-stage heart failure. But when they came out with LVADs, the most recent, the HeartMate 3, which is the most recent LVAD out there, at 2 years, I should say the survival. Let's do that because I think this is going to be confusing. So the survival at 2 years for those without an LVAD, 5 to 10%. This is probably going up, right? That study was a number of years ago, so their survival is probably a little higher, even in the non-LVAD group. But with those with a HeartMate 3 at 2 years, I think the most recent study was somewhere like around 75 or even closer to 80% survival at 2 years for those that got the HeartMate 3 LVAD. So you can see huge improvement in survival, right? Quality of life and all those kinds of things benefit from having this left ventricular assist device. So as you can see, this device does seem to help people. It's really interesting though. We're going to come back up to this picture to talk about the components of the device itself. I want to start with a more simplistic drawing on the anatomy and physiology. And to understand what an LVAD is doing, we have to understand how the heart works. Okay, so this is a depiction of a heart. For those of you familiar with this, bear with us. For those unfamiliar, the components we have here, this is the right atrium. Okay, the right atrium gets venous blood. This is deoxygenated blood from the body, so it's already pumped around the body and it's coming back in the veins through the inferior vena cava, the IVC at the bottom here, and then through the superior vena cava, the SVC at the top, and it pumps into the right atrium. Okay, that blood goes through the right atrium, this is the tricuspid valve, into the right ventricle. The deoxygenated blood in the right ventricle then goes through the pulmonic valve right here, and this gets pumped into the lungs, okay? The lungs obviously oxygenate the blood, and then they pump it back to the left side of the heart, into the left atrium. That oxygenated blood goes through the mitral valve, into the left ventricle, and then it goes out the aortic valve, right, up the aortic arch, and this is where the oxygenated blood starts going to the body, right? There's these arteries that come off the aortic arch that go to, the head, the brain, the arms with oxygenated blood, and then the descending aorta kind of comes down this arch, goes behind the heart, right? So I'll put a dotted line because it's kind of behind the heart, and this is the aorta, And this takes all that oxygenated blood that goes to the rest of the body, right? Kidney, liver, legs, etc., etc. I don't need to write it all out. So if we were to kind of zoom out and draw it on this nice stick figure, very happy, they're smiley because we're talking about LVADs today. They have a very long neck, apologies, and I'm going to draw their heart a little bit low, right? So the heart's going to be kind of sitting below their arms. And stick with me, I'm not the best of the drawers, but what we have here, right atrium over here, right ventricle here, left atrium, left ventricle, and the oxygenated blood gets pumped out of the left ventricle, right, and it goes down. Oh, let us mute this, apologies. No, that's not what we wanted. We wanted to mute. Good. Goes down the aorta, and the aorta kind of branches tons of arteries, right, off of it, right, to go to the bowel, to go to the kidney, right, and it comes down and branches and goes down to the legs, right? There's the iliac arteries, femoral arteries, the celiac artery, superior mesenteric artery, inferior mesenteric artery, renal arteries, etc., etc. So all this is oxygenated blood, blood with oxygen. So you see that left ventricle is critically important. If that left ventricle can't squeeze adequately, then we're not going to be able to pump the oxygenated blood to the body. You can't live, right? If you can't get oxygen to your tissues, you can't live. Your tissues will die. They need oxygen to live. So patients with heart failure have a decreased squeeze. Their left ventricle, there are some subtypes of heart failure, and we won't discuss it in this lecture. There's diastolic heart failure and systolic heart failure, but we'll maybe do another video on heart failure if y'all are interested. But the heart cannot squeeze adequately, right? Quite literally, the heart contracts. This left ventricle squeezes inward and contracts in, and then it pumps that blood out the atrium. And there's a valve here that's closed, right? Or sorry, out the aorta. So this valve's closed, so blood can't go back to the atrium. It comes out of the left ventricle and goes into the aortic outflow tract, aortic arch, and out the aorta to the rest of the body. So if this is not squeezing as well, it's called heart failure, right? An ejection fraction is kind of what we measure it in. And a normal ejection fraction is, usually above like 55%. So heart failure is when you have a low ejection fraction, not able to eject blood out of your left ventricle as well. And it's literally a percentage, right? So normal is greater than 55%. So people out there without heart failure, the percent of blood they're ejecting out of their left ventricle, if we say, the whole left ventricle is 100%, you eject normally about at least 55% of blood out of your left ventricle. When you have heart failure, that number's way down. And you can imagine, right, if your ejection fraction is only 10%, you have severe systolic heart failure because you're only ejecting 10% of the blood out of this left ventricle. The rest is just sitting in there because you have a weakened squeeze, a weakened heart. And that's where the left ventricular assist device comes in, the LVAD, right? Because that left ventricular assist device helps pump blood around the body. So I'm going to zoom into this graphic over on the side here, and we put a citation below it. It's not our work, so we'll link this study in the video description if you want to kind of go to it, but credit where credit's due, this is their image. But it shows a pretty decent outline of what these devices look like. So hopefully this looks like the heart, right? This is the right atrium, right ventricle. This is that pulmonary outflow tract that goes to the lungs, right? Then that blood comes back into the left atrium, left ventricle, and then here's that aortic outflow tract, aortic arch. So what the left ventricular assist device is doing is they surgically implant this tubing into the left ventricle. Literally, it goes through the wall of the heart and sits into the left ventricle. This is the inflow cannula. But don't get confused on inflow because it's actually inflowing into this pump, right? So it's sucking blood out of the left ventricle, sucking blood out of the left ventricle into this pump, and we'll talk a little bit more about the pump. That pump then pumps the blood to the outflow cannula out of the pump, and this is surgically implanted into the aorta, okay? So as we said, the aorta is what pumps blood to the rest of the body. If we go down to our terrible drawing here, this is the aorta. And the aorta pumps blood to the rest of the body. So the LVAD has part of its tubing here. It sucks blood out of the left ventricle. It goes to, a nice pump. And that pump then shoots that blood through another outflow cannula directly into the aorta. And then it pumps that blood into the aorta so that the oxygenated blood can go and get to the rest of the body. So if we look back up, right, you have your inflow cannula, and when they talk about inflow, it's as compared to the pump itself, so it's flowing into the pump itself, sucking blood out of the left ventricle through the inflow cannula into this pump. The newest LVADs, the HeartMate 3, and there's multiple kind of LVADs out there, but HeartMate 3 tends to be the newest one. This type of pump is an axial pump. It actually uses magnets. There's no kind of bearings or anything, which we'll get into a little bit. And then that pump pumps that blood to the outflow cannula that's surgically implanted into the aorta, and that pumps the blood around. So people are walking out in the world with this. This is a person, right? And they have their LVAD, right? We talked about here's their heart. The LVAD sucks blood out of the left ventricle, goes through this pump, goes into the outflow tract, into the aorta, and then that blood gets through the aorta and kind of goes down to the rest of the body, as it would. But what you can see here is that this individual, you wear the LVAD, right? You wear it on your person, because what you need is you have this cable. You see this cable right here that is in the body, comes out of the abdomen, and then is connected to this pack. This is called the drive line, right? And the drive line is how this pack here, all right, this is the external control unit, controls the LVAD itself. This is how you can change settings and things. You could look at settings. And then you have your two battery packs, right, because this needs to run on battery. So when you're at home, you could be plugged in, but when you're walking around in the world, you need battery packs to then run this. Without battery, the pump cannot run itself, right? The pump will die. It needs battery just like anything else. So you can see that people with LVADs kind of walk around with all these things, but as compared to, you know, them just taking medical therapy and not surviving, this is, in many people's mind, a big upgrade, but certainly it's patient dependent. You know, obviously everyone has different preferences for how they're willing to live, but that's what the general structure looks like for people who have an LVAD, who are kind of out in the world. I'm going to zoom back out. Let's see, let's zoom in just a little bit. Okay, so we talked about the anatomy, physiology. We talked about what that looks like. What are the indications? Who benefits from an LVAD, right? I told you there's an increased survival at 2 years, okay? There's decreased symptoms for many people with end-stage heart failure. But there are specific indications for who qualifies for an LVAD. Obviously, this is a surgery. It's a significant surgery. These patients need really close monitoring at outpatient appointments. They need to be on special blood thinning medications and all that. So these are all subjective, but some rough guidance is that ejection fraction, right? How much that left ventricle, LV, left ventricle EF ejection fraction can pump blood out. It's got to be very low, less than 25%. These are all kind of dense details, and I'm going to skim over these briefly, but for those interested, certainly can do a deeper dive later on. But NYH, New York, is it Heart Association? I think so. This is classes of heart failure based on symptoms, and this is essentially advanced symptoms of heart failure. These symptoms and ejection fraction need to be refractory despite optimal medical therapy. So you can't just not have started any medications and come with this heart failure and get an LVAD. And then patients who are really sick, they're on inotropes, which are medications that help the heart squeeze harder, or mechanical circulatory support like an intra-aortic balloon pump. We've done a video on intra-aortic balloon pumps, so definitely check that out if you're interested. So all these patients would qualify. But in addition to that, there has to be something more, right? Because LVADs are a really significant kind of investment. So who benefits most? Well, those with these symptoms, and then also as a decisional tree based on bridging to a certain endpoint, right? So those who qualify for a heart transplant, while they're waiting to get that heart transplant, they can get an LVAD as a bridge to transplant, right? Help them survive until they can get a transplant. In addition, those being worked up for a transplant, they can get an LVAD as a bridge to a decision if they're going to qualify for a transplant. Sometimes people's hearts get really sick, right? But if you expect that heart to recover, you can get an LVAD as a bridge to recovery. And then once you recover, you obviously don't need the LVAD anymore. And then now we actually do it as destination therapy too, which means for patients who don't qualify for transplant, they're not going to recover, and it's already been decided, right? So it's not a bridge to transplant, it's not a bridge to decision, it's not a bridge to recovery, but they have end-stage heart failure. We've now seen that people can live, some people can live better, quote-unquote, better lives with LVADs, less symptoms, longer lifespan. So it can actually be a destination therapy, right? They're not going to end up with a transplant. The heart's not going to get better, but they get an LVAD, so they can live a more kind of fruitful life until, you know, they succumb to their disease. So it's destination therapy. So you'll see these sometimes, right? Like bridge to transplant, destination therapy, all that. That'll often be in like the advanced heart failure note and those types of things. So these are the indications, those with end-stage heart failure, despite medical therapy, as then a bridge to transplant, bridge to decision about a transplant, bridge to heart recovery, or as destination therapy. All right, are there contraindications? Are there patients who can't get an LVAD? Well, some of these contraindications are what we call kind of hard or absolute, and some are kind of soft contraindications. One is right heart failure. So as we mentioned, there's two sides to the heart. You can even put a line right down the middle. Right, so you have the left side, right, left atrium, we talked about this, left ventricle, and then you have the right side, right atrium, right ventricle. And as we said, the right side pumps blood to the lungs, so it goes out to the lungs, and then it comes back in to the left side of the heart, right, and be kind of a dotted line to the left atrium, goes to the left ventricle. And then the LVAD sits in the left ventricle, pumps blood out to its motor, right, which then pumps blood to the outflow tract into the aorta, and then that blood that the LVAD pumps into the aorta gets shot out to the rest of the body. But to get blood to the left side of the heart, the right side of the heart has to work, right? Because that right side of the heart has to pump the blood to the lungs that then returns to the left side of the heart to get pumped to the rest of the body. So if the right side of your heart is not working, LVADs often don't help you because you need the right side of the heart to work to pump blood to the left side of the heart, if that makes sense. All right? So right heart failure can be a relative contraindication. Neurologic compromise. What this means is those with devastating neurologic injuries. Getting an LVAD, again, requires a huge surgery. You need to be on blood thinners, all these medications, frequent appointments. You have to make sure your battery life stays good. There's a lot that is required to maintain an LVAD. So if you have a profound neurologic injury, often that patient is not a great candidate to get an LVAD. In addition, coexisting severe terminal illness. So if you have another disease that you're going to die from in the near future, often they won't give you an LVAD because it's not really going to prolong your life because you're already going to succumb to that other disease. Another big contraindication is bleeding. This is a relative contraindication, but to have an LVAD, to have a left ventricular assist device, you have to be on a blood thinner, anticoagulation. Often this is Coumadin. In addition to that, you have to be on aspirin, right, ASA. So if you already have some severe bleeding issue, you can't really get an LVAD at that time. But again, that's relative. You know, there's not too many bleeding conditions that are at least common that would be an absolute contraindication. Usually you can try to take care of the bleeding first, give some time, and then possibly be a candidate for an LVAD. Anatomic limitations, though, is a big one. As we mentioned, I wonder if I can erase some of this because I clogged it up, although the picture's fine. So you have to put this big outflow cannula in the left ventricle. So you have to have the anatomic space to do that. Let's say you have hypertrophic cardiomyopathy where the walls of the heart are very thick. So if I were to draw another heart, right atrium, left atrium, here's the ventricles, this is right ventricle, this is left ventricle. So as you can see here, you kind of have this thin myocardial wall, plenty of space in the actual cavity for this cannula to sit. But if you had a really thickened wall, let's just say your cavity was only this big and all this was really hypertrophic heart wall, there's not really enough space for a cannula to sit in that little cavity, right? So that would be an anatomic limitation. In addition to that, technical limitations. So if you have profound obesity where the LVAD just can't physically pump enough blood around your body because you have so much adipose tissue that you can't get enough pump flow from the LVAD to get to the rest of the body, that would be another limitation. All right, so these are contraindications, but again, a lot of these are kind of what we call relative contraindications. Something that the advanced heart failure team and the multidisciplinary LVAD team at the institution that you were at would kind of all talk about and figure out what makes sense for a patient and what doesn't. All right. You know, the only other thing about anatomy, now that I'm thinking about it, that I didn't say is remember the heart keeps beating. So not only are you getting flow from the LVAD, so LVAD sucking blood out of the left ventricle, going through the pump into the aorta, shooting that blood into the aorta to go around the body, but the heart is still working. So even if your ejection fraction is only 15%, that means your heart is still able to squeeze 15% of its blood out of the left ventricle into the aorta. So, you know, patients get both their native ejection fraction as well as the LVAD flow to help perfuse the body, just if I didn't mention that above. Okay, so pump parameters. This is, at the end of the day, a pump. The LVAD is a pump. And I put HM3 here because these are somewhat specific to the LVAD you have. Again, HeartMate 3 is the biggest one. I also was going to talk about alarms, but I'm going to do a separate video on LVAD alarms, kind of a deeper dive on it. So keep an eye peeled for that. We'll link it in this video's description when it is out as well. So the pump parameters, there's 4 pump parameters, all right? Speed, power, flow, and pulsatility index. And these are literal things on the LVAD itself, right? I'm going to scroll up. We said LVAD patients have this external control unit, right? These 4 parameters are on this external control unit. You can get them from that, okay? And they're relevant to how the LVAD is working and the physiology going on in the patient's body. So the speed is just that, the speed of the blood flowing, and that's in revolutions per minute RPM. And it's about 3,000 and 9,000 RPM would be kind of within the parameters of quote-unquote normal, although I think 4,000 is pretty close to normal. This is revolutions per minute of speed. All right, the power is the direct power measurement of the motor itself. So if you think about an LVAD, what you think about is that there's an actual motor, right? And the motor is pumping that blood around. So the power is a measurement of how hard that motor is working to pump the blood around. And again, that can tell you some things about the patient's physiology. If that motor is working harder or less hard, that might indicate certain things about the patient. Third is the flow. This is actually a derived an estimated value. This is not a direct measurement, right? Speed and power, these are direct measurements. Whereas the flow is derived. And the derivation is based on the directly measured speed, the directly measured power, as well as the patient's hematocrit. The hematocrit is how many the red blood cell load they have going around. And this is 3 to 6 liters per minute. So the flow is the actual kind of quote-unquote cardiac output, right? The liters per minute of blood that pump is flowing around the body. It's about 3 to 6 liters per minute. The pulsatility index is a little more complex, right? So as we mentioned, the heart is still beating. As we mentioned, I'm going to do this terrible drawing over and over again for some reason, right? You have your LVAD coming out of the left ventricle, going into its outflow tract, into the motor itself, which is then going, sorry, I think I said outflow tract, but this is the inflow tract here, going into the outflow tract, which is then going into the aorta. And we'll draw the aorta here, which kind of comes out of the left ventricle into the aortic arch, into the descending aorta, the rest of the body, right? And then this outflow tract's kind of got its big cannula going into the aorta. But that heart is still beating. There's still native beats going on. So the pulsatility index is the the LVAD controller unit itself averages the pulsatility of the heart, the squeezing of the heart over 15 seconds, and then translates it into a reading from 1 to 10. So as one can imagine, that pulsatility index, when the heart squeezes, it'll change how the pump is flowing, right? Because how this blood goes into the pump, this inflow cannula, would change whether the myocardium was kind of squeezed and contracted down or relaxed. So that's what the pulsatility index is measuring, right? It's measuring over 15 seconds how the pump flow changes when the heart is squeezing. And then it gives it a number again, 1 through 10, which can again be a hint for some of the physiology of what's going on with the patient. And again, look for an upcoming video on all things alarms, because I think LVAD alarms are really important, but they're kind of next level. I didn't want to include them in the LVAD basics. I think they require a little bit more discussion on their own. So those are 4 things that the controller unit of the LVAD will show you: the speed, the power, the flow, the pulsatility index. The flow is the only thing that is kind of estimated and derived. The rest of them are direct measurements, and all of them can tell you kind of about the quote-unquote normal on the LVAD. Something we sometimes talk about is like, we'll call it like the rule of 4s, right? That all these should be about 4 something, right? Like about 4,000, about 4 liters per minute. All right. So kind of rule of 4s can at least give you a ballpark estimate of what the quote unquote normal is in setting of pump parameters. All right, so how do we evaluate an LVAD? This is really complex, and this is certainly not a comprehensive list, but when an LVAD comes into the clinic, or you have an LVAD, or you see one in the emergency department, you just are curious how to evaluate an LVAD, there's a handful of things you should do. The first is always to reach out to the LVAD team. They want to be involved. They follow patients with LVADs really, really closely. There's usually a coordinator on call 24 hours a day, depending on the institution you're at. Call the LVAD team, let them know that an LVAD patient of theirs is at your institution, and they certainly will probably know that patient and want to be involved. You can auscultate the heart and listen for a hum, right? You should hear a hum. This is literally the machine, the LVAD pump working, so you should always hear a hum. No hum, bad news bears. Always check the patient's battery life. Again, if the patient is not physically plugged in to charge, they have a battery, and those batteries die. And if the battery's dead, the LVAD pump is not working. So always check the patient's battery life. All right. Look at the LVAD to see if there's been any recent LVAD alarms. Remember, future video, but this gives you a lot of insight. If there's been alarms, you need to think about and address those alarms. If there hasn't been, that kind of crosses it off the list, right? The LVAD seems, there's a hum, good battery life, no alarms. That implies the LVAD's probably working okay. Certainly exceptions to that rule, but for the most part. Also look at the drive line for signs of infection. I'm going to scroll back up to that picture to remind you all what the drive line is. Right, the drive line is literally this line that goes from inside the patient's body on the pump of the LVAD, goes through their abdomen, comes out the skin of their abdomen, and plugs into the controller unit. So that's the outside world, right, communicating with the inside world, because that drive line comes out of their body, goes to the controller unit, and obviously from the controller unit, the drive line from outside the body goes back in the body, in the abdomen, to the actual LVAD itself. So you always want to look at that site, make sure there's no redness, make sure there's no swelling, make sure there's no drainage, no pain, because drive lines do get infected, which we'll talk about in a second. Always on a coagulation panel. Remember, these patients are on anticoagulation, AC anticoagulation. Most times it's Coumadin, so you want to check their INR, make sure it's not too high, not too low, get that sweet spot. Electrocardiogram and telemetry monitoring. These patients are high risk for ventricular tachydysrhythmias, so always get an EKG and have them on telemetry monitoring. Auscultate the map. This is essentially how do we check the blood pressure of these patients, right? Because blood pressure, the cuff itself, isn't always dependable. So what you can do is you can inflate a cuff and put a Doppler on the brachial artery, and then when that pulse comes back, that is going to be the map of the patient. So what this looks like is you literally put a Doppler on the brachial artery with a blood pressure cuff proximal to that, inflate the blood pressure cuff, right? And then slowly let the air out of the blood pressure cuff until that pulse returns. Good. And, you know, a normal map in these patients, probably somewhere around 60 to 80 millimeters of mercury. Now, the blood pressure cuff sometimes will work. It depends a lot on what that patient's actual left ventricle is doing. But the LVAD itself is a machine, right? It's not pulsatile. It gets a little more complex, right? Because the HeartMate 3 does have kind of this pulsatility purge thing it does. But if you're trying to feel for a patient's pulse, you won't always feel one, even when they're doing just fine, because that LVAD itself is just sucking blood out and circulating it through. And that's just a constant flow, whereas the heart is squeezing, relaxing, which is how you get that pulse, right? Squeeze, relax, squeeze, relax. This is pulse, nothing, pulse. So if the heart itself does not have a lot of function left because they have severe systolic heart failure, so that left ventricle isn't squeezing robustly, you might not feel a pulse on these patients, even though they're doing just fine and the LVAD's working just fine. Right? It doesn't get really tricky when they don't have a pulse and they don't look just fine, but topic for another video. But try to feel a pulse if you can't feel one, though, and the patient has a good hum, good battery life, no LVAD alarms, they're awake, they're talking to you. Use this method where you inflate the blood pressure cuff while using a Doppler on the brachial artery to see what their map is, because they will have a map still. They just might not have a pulse. Okay, and then volume assess and perfusion assess these patients. So make sure they're not swollen, they don't have a bunch of fluid overload, and then feel their extremities, right? Make sure they're warm and well perfused, that they're not cold, to imply they're in kind of blossoming cardiogenic shock. So this is kind of the quick and easy evaluation for these patients. Certainly a lot more to be done here. You know, these patients can sometimes hemolyze their red blood cells, so a CBC to look for their hemoglobin is important. If they do have a low hemoglobin, thinking about GI bleeding, but also hemolysis is important. You know, these patients can get very, very sick, but here's kind of the quick and easy for them. All right, last but not least, complications. So LVADs are a machine implanted into the heart. So there are going to be complications. As we've gone through different iterations of LVADs, and now we're to this kind of HeartMate 3, these complications have been decreased, but they are present. One of the big complications is bleeding. Okay, specifically GI bleeding. Some estimates are kind of up to 10 to 25% of patients with LVADs will have a GI bleed at some point. And this is for several reasons. The obvious one is that these patients are often on anticoagulation, right? Things like Coumadin, or warfarin is another name for Coumadin. In addition to that, though, given that LVAD kind of sucks blood and shoots it around their body, it also can mess with their von Willebrand factors, which makes them more prone to bleeding. They can also have lower platelet counts. And without pulsatile flow, which this is going to sound bizarre, but it's true, they have an increased risk for AV malformations in their gut, arteriovenous malformations, which are called AVMs for short, and these can bleed. So all these together really increases the risk for bleeding, especially GI bleeds. In addition to that sepsis or infection, about 20% of these patients can get an infection. Oftentimes it's from that drive line, right? We said evaluate that drive line. The drive line goes from the external world into the patient's body, so high risk for infection. Many of these patients need blood cultures, close monitoring of their drive line, and kind of always have a clinical suspicion for sepsis or infection if they're coming into the hospital for really any complaint. RV failure is another big one. And why is that? Well, it's because of what we talked about. Let's go see if we get a good picture. Right side of the heart, left side of the heart. Right ventricle, this would be RV failure. That LVAD is sucking blood out of their left ventricle and shooting it around their body. But that blood comes back to the right side of the heart. So if the LVAD is doing its job and it's flowing a great amount of blood back, over time it can overload the right side of the heart, and we see that up to 10 to 50%, so kind of a wide margin of patients can get RV failure over time, because that LVAD is circulating so much blood around the body, and all that blood goes back into the right side of the heart, and it can cause that right ventricular dysfunction. Aortic regurgitation, what is that? We're going to scroll back up again. Hopefully we have a picture that I just haven't absolutely destroyed. We're going to do some erasing on here so we could see a little bit better. So the aortic valve is the valve that's right here, okay? Let me get a little darker. This is the aortic valve, and the aortic valve is where blood from the left ventricle gets pumped through the aortic valve into the aorta. And as we said, an LVAD sits in the aorta, so it sucks blood out of the left ventricle and shoots it into the aorta. Over time, that's a lot of kind of pressure on the aortic valve, and you can get regurgitation, which is where blood goes the wrong way. It goes from the aorta through the aortic valve back into the left ventricle. And there's a number of reasons that can starts to happen. One of those reasons is, since you're sucking so much blood out of the left ventricle, less blood is being squeezed from the left ventricle through the aortic valve, so that aortic valve can start to kind of degenerate over time. And as it degenerates, it gets aortic regurgitation, 10 to 35% of patients. The reason this is so significant is because it makes the LVAD much less effective, right? Because if you're, I couldn't help myself, I have to draw it again. Okay, so this is left ventricle here, right? And again, you're pulling blood out of the left ventricle to the machine, and then going into the aorta, and the aorta circulates blood around the rest of the body, right? So it's implanted here in the aorta. But if you have aortic regurgitation, and you're shooting all this blood into the aorta, that's a lot of pressure in the aorta. And if the aortic valve regurgitates the wrong way into the left ventricle, a lot of this blood will end up going back into the left ventricle. Much less of that blood will go forward, and that'll make all of this worse. So it can really affect patients. You should always consider aortic regurgitation, because many patients develop it over time. And then another one is stroke. Anytime you're pulling blood out of the body into a machine, there's a chance of blood clots forming. Right? You can get blood clots in the machine itself. You can get it in the cannulas, and even having kind of these foreign bodies in the left ventricle or in the aorta. Now, this has gotten a lot better over time. This number used to be much higher, but still around 10%, people say, of patients with LVADs can develop stroke. So these are some of the big complications: bleeding, sepsis or infection, right ventricular failure, aortic regurgitation, and stroke. Although these patients are higher risk for lots of conditions, just because they're very chronically ill, and they have this LVAD, this machine that's literally pumping blood around their body for them. So just as a brief introduction, these are 3 of the 4 things you can see on the LVAD controller unit. Flow, power, pulsatility index. The other one is speed, although for the sake of today and with alarms, we're going to talk about flow, power, pulsatility index. What these measure gives us some insight into the pathophysiology that could be going on with the patient. So for the lecture today, as you can see, we're going to have this flow, power, pulsatility index, and we're going to talk about whether the flow, power, or pulsatility index are up, down, variable as related to each of the clinical conditions below, okay? Because the flow, power, and pulsatility index can then give you insight into whether the patient might be hypovolemic, hypervolemic, hypertensive, etc., etc. Things to remember when we're talking about LVAD kind of alarms and parameters is that LVADs are preload dependent, meaning the flow and power depend on the preload, and they're afterload sensitive, okay, meaning the afterload affects these things as well. So when the preload is robust, the flow is high. When the afterload is too high, they're afterload sensitive, right? So that can drop the flow. If we're talking about equations in and of themselves, I wanted to write just a couple equations here. So these are the equations for flow, power, pulsatility index. One thing to note about power is that power is actually a direct measurement, all right? It's not extrapolated with an equation. So this is just a direct measurement, whereas flow and pulsatility index require equations. The flow is the speed divided by the pressure at the inflow. This is essentially the left ventricle pressure. That's where the inflow cannula lies. Again, check out that LVAD basics video linked in the video description if this is all unfamiliar to you. Minus pressure at the outflow. So this is the aorta, right? Because the outflow sits at the aorta. The LVAD sucks blood out of the left ventricle, goes through the pump, and then injects it into the aorta. So it's speed divided by pressure at inflow minus pressure at outflow, which essentially means it makes sense, right? So the flow is going to be based on the speed of the pump divided by the pressure at the inflow minus outflow. So the pressure that that speed is pushing against. All right, again, power is direct measure, whereas the pulsatility index, this is a measure that the LVAD gives you that essentially senses how the flow changes when the left ventricle is contracting, right? Because the heart is still beating as the LVAD is circulating blood. So the pulsatility index is the maximal power minus the minimum power divided by the average power, and this is over 15 seconds. So essentially what happens is the LVAD tracks the power over 15 seconds, and the heart is beating within those 15 seconds. And then it subtracts the minimal power from the maximal power divided by the average power to give this pulsatility index. So it's a measurement of how the flow changes as the heart's inherent contractility is functioning, okay? And we're going to return to all these concepts as we talk about these clinical conditions. So I think it'll start to add up a little bit more as we talk about these clinical conditions. So with no further ado, LVAD alarms based upon the pathophysiology going on. So starting with hypovolemia, right? Hypovolemia, as we all know, is low volume or volume down or not enough volume. So how would hypovolemia affect the flow, power, and pulsatility index on an LVAD? Well, what we said is that LVADs are preload dependent, right? So if you have hypovolemia or low volume, you're going to have low preload, a decreased preload. And what's going to happen then is the flow is going to be low, and as such, the power is going to be low, right? Because the power is the direct measure of work. So if there's low flow, and flow is based on the speed, the revolutions per minute, the RPMs of the motor, if you're hypovolemic, meaning you don't have enough preload, meaning you have low speed, right? Low flow, it's going to be working less hard. The power is going to be low. The pulsatility index is going to be variable depending on kind of some complexities of the LVAD model itself and some called kind of the HQ curve, but it'll be variable. But low flow, low power for hypovolemia. So you see a patient, you're like, oh, are they volume down or are they not? They have an LVAD. Look at their flow and power. If the flow is down and the power is down, it could suggest that, although as we'll get into, it could also suggest a number of other things. So what about the opposite, hypervolemia or volume overload? Well, again, we said that LVADs are preload dependent. So if hypovolemia is low flow and low power because there's not enough preload, which decreases flow and decreases power, hypervolemia is going to be a high flow and high power state, right? And just like hypovolemia, the pulsatility index is going to be variable. It's going to depend on kind of this complex curve. So this goes back to this rule here. LVADs are preload dependent. So low preload, decreased flow, decreased power. High preload, increased flow, increased power. What about hypertension or high blood pressure? Well, what did we say, right? We said that LVADs are also afterload sensitive. Afterload is kind of like the pressure the heart is squeezing against. So hypertension is going to increase the afterload. Okay, and as such, as we could guess, if the afterload is increased and if they're afterload sensitive, hypertension is going to decrease flow, right? And it's going to decrease power, right? Flow and power follow each other. What about the pulsatility index, though? The pulsatility index is actually going to increase. So there's going to be more variability in the flow beat to beat with a high afterload state. All right, what about right ventricular failure? And I'm going to try to start baiting y'all into thinking about this before I write it out here. So right ventricular failure, obviously the right ventricle pumps blood to the lungs. Then that blood goes into the left side of the heart, including the left ventricle. So the left ventricular preload is dependent on right ventricular function. AKA, if the right ventricle is not working, it is unable to pump preload to the left side. What did we say? LVADs are preload dependent. So if there's a right ventricular failure which decreases left ventricular preload, what's going to happen to the flow and power? Hopefully y'all guessed it. The flow is going to be low because you have less ventricular preload, and the power is going to be low, right? These follow each other. Pulsatility index, as with many things, is variable. Maybe we'll do a whole separate video on pulsatility index just because there's a lot of complexity there. All right, so if we're going to continue on with this, I'm going to scroll down a little bit to pull them all in here. What about aortic insufficiency or a leaky aortic valve, right? Aortic regurgitation is another kind of verbiage for it. What's going to happen to flow and power and pulsatility index? Well, if the aortic valve is leaky, what's happening is as the LVAD outflow cannula pumps blood into the aorta, some of that blood is going to return to the left ventricle. It's going to go the wrong way. So if we draw, for those who've watched these videos, you've seen a lot of my bad drawing of a heart, right? This is right ventricle, right atrium, left ventricle. And as we have talked about, you have your LVAD inflow tract, which sucks blood out of the left ventricle into a motor, right? And that motor then has the outflow tract, which goes into the aorta. The aorta, we'll do it red. The aorta is the large blood vessel that comes out of the left ventricle, right? We'll kind of do dotted lines because this will be behind the heart. Comes out of the left ventricle and pumps blood to the rest of the body. And this LVAD outflow tract has a cannula in the aorta. So it's sucking blood out of the left ventricle through the motor up and injecting it into the aorta to pump blood to the rest of the body. So as we mentioned, aortic insufficiency or aortic regurgitation, this valve here, right, there's a valve, an aortic valve, that should be one way. It shouldn't let blood return to the left ventricle. But with aortic insufficiency, some of this blood that the LVAD's pumping into the aorta is going to regurgitate back into the left ventricle. So you can almost think of it like it's increasing left ventricular preload because some of this blood is going back into the left ventricle. As we talked about, LVADs are preload dependent. So if you're increasing left ventricular preload, what do you expect for the flow and power? The flow is going to be high, and the power as such is also going to be high. What about the pulsatility index? Well, you're going to have less left ventricular variability in volume, right? Because a lot of this volume is going back into the left ventricle. Okay, so you're going to actually have a lower pulsatility index. Because as we said, pulsatility index is kind of this variability in flow when the left ventricle is contracting. But the volume in the left ventricle in aortic insufficiency is going to change less because some of the blood that the LVAD's trying to pump out is returning back to the left ventricle, so you're going to have a decrease or a lower pulsatility index. What about thrombus in the pump, right? What if this pump is full of thrombus? All right, what are you going to see? Well, if we think about power, we're going to get away from the preload and afterload comments for this one. If we think about power, power is how hard the pump is working. If the pump is full of blood clot, do you expect it to work harder or less hard? Harder, right? So the power is going to be way up. We're going to do 3 arrows here. And, the flow is going to say it's up, right? But it's actually low because you obviously have trouble flowing blood through the pump. But the pump sometimes gets confused, again, depending on the LVAD model, and might falsely say that it is up, but it is down. And the pulsatility index, variable unchanged, per usual. All right, what about inflow or outflow cannula obstruction, right? So we have these cannulas. This here is the inflow because the motor is kind of baseline, so it's inflowing to the motor. This is the outflow. What if you had kinking of this or clot in this? What would happen to the flow and power? Well, you're unable to flow blood through, right? So you're going to have a low flow. And since you have a low flow, there's not clot in the motor, right? So the motor is not working any harder. It's actually working less hard because there's less flow going through the cannulas into the motor. Whereas if you have thrombus in the motor, as we mentioned, thrombus in the motor, you get a lot more work by the motor, so the power's up. But this is not thrombus in the motor, it's thrombus in a cannula. So it's going to decrease the flow, and as such, the power is going to go down. All right, what about the pulsatility index if there's kinking or clot of one of these cannulas? The pulsatility index is going to decrease. So now we're starting to kind of see some patterns here. All right, what about ventricular arrhythmias? The patient comes in with persistent ventricular arrhythmias. For this, we're going to go back to our preload and afterload and contractility comparison, right? So we said that the heart is preload dependent and afterload sensitive. So if you have a bunch of ventricular arrhythmias, do you anticipate the heart is going to have good squeezing, right? The right ventricle is going to have a good squeeze to pump blood to the left ventricle when it's in ventricular tachycardia. The answer is no, right? So the left ventricle is not getting appropriate preload, and as we know, it's preload sensitive, so if it's not getting appropriate preload, flows down, power's down. What about the pulsatility index, right? Start thinking about this one. If you're not getting a lot of concentric contractility, squeeze of the left ventricle, you know, some people equate pulsatility index to kind of the contractility, how well the ventricle is able to squeeze. If it's in ventricular tachycardia, it's not going to be squeezing very well. Pulsatility index is low. Okay, last but not least, sepsis. This one is a little bit trickier, because we said preload dependent, afterload sensitive. Well, in sepsis, what happens is our systemic vascular resistance drops, right? We vasodilate in sepsis. So the afterload is going to decrease, right? The heart is squeezing against less afterload because we vasodilated, our systemic vascular resistance decreased. So if we're afterload sensitive and we have vasodilation or decreased afterload, what's going to happen to our flow and power? Our flow is going to go up, and our power is going to go up, right? They follow each other. So less afterload because we're vasodilated, increased flow, increased power. What about our pulsatility index? Pulsatility index often goes down in sepsis. So the flow power here, I think, is much more intuitive. The pulsatility index is this kind of complex relationship that doesn't fit perfect bills. And I think maybe let us know if we should come out on a separate video, like on pulsatility index, and kind of dive into the nitty-gritty details, because it is a little more confusing, whereas the flow power kind of equates to this preload dependent, afterload sensitive state that we often see. All right, thanks for sticking around. So suction events with left ventricular assist devices. So a suction event, the idea here is that there's actual suction happening between the LVAD inflow cannula, right? For those of you unfamiliar or less familiar who just need a brush up on things, this is an LVAD, right? LVAD is a surgically implanted left ventricular assist device. This is the heart here, right? You have the right ventricle, right atrium. This is the right ventricular outflow tract into the pulmonary vasculature. This is the left atrium, left ventricle, the aortic outflow tract here that goes into the aortic arch. All right, this is not our graphic. Props to this team here. Seeing it all, and we will put this link in the video description. They should get the credit for the image that they put together. But what an LVAD does is this inflow cannula sucks blood out of the left ventricle. It goes through the inflow cannula into the pump, and this pump then shoots the blood through the outflow cannula into the aorta to then be circulated around the body. So what's happening with a suction event is there's literally suctioning happening with this inflow cannula as it's trying to suck blood. Some of the myocardial tissue actually gets suctioned onto this. As you can imagine, if someone is dependent on an LVAD to pump blood around their body, and when they're trying to suck the blood out of the left ventricle to then pump it around their body, a suction event where that pump cannot suck blood in is going to be potentially catastrophic, potentially deadly. This is most common in kind of the first month for when you have your LVAD, because sometimes it takes some fiddling. As one could imagine, the speed in which the LVAD is sucking the blood out of the left ventricle, the speed is potentially a cause here for suction events. Sometimes you need to decrease the speed, which is why kind of the first month tends to be when you see more suction events, as the titration of the LVAD and the heart are kind of becoming adapted to one another. But what we're talking about with suction events here is this is literally the left ventricle collapses, okay, and the septum deviates towards the inflow cannula. To put that in the picture, it's what we just talked about. Here's the left ventricle. It collapses, and the septum, right, the intraventricular septum often deviates towards the LVAD inflow cannula, which is sucking the blood out, and causes intermittent transient obstruction. Things that can cause suction events, it's super variable, super diverse. Really, anything that decreases the preload. If this left ventricle is empty and there's less blood in there, it's going to be kind of less expanded, right? Less dilated. And if it is more empty, these walls, it's going to be easier for them to kind of come together and lead to a suction event on this inflow cannula. Also, anything that positions the cannula closer to the septum. It's this intraventricular septum that often goes inwards towards the suction cannula and causes these suction events. So if this cannula is kind of directed at an angle more towards the septum, that can lead to increased suction events. So kind of cannula positioning and anatomy. So anything that decreases preload or anything that positions the cannula closer to the septum. When we think about what those things are, again, it can be a number of things, really diverse pathology. One, as we just mentioned, is simply inflow cannula position, right? If you just get an LVAD, they just implant it, right? And you're within the first month or so. If that cannula is positioned, closer to the septum or kind of directed towards that septum, that can cause an increase in suction events. So inflow cannula position is important. Now, if someone has had their LVAD for months and months and months and they haven't had suction events and all of a sudden start having suction events, that's not going to be inflow cannula position, because unless that LVAD's gotten, moved around, which is not likely, this usually is something that happens right after implant of the LVAD. Speed changes is another one. As we talked about, the rate in which the LVAD is sucking blood out of the left ventricle is going to contribute to this left ventricle collapsing. Speed is something you have to change, though. We've talked about that in those previous videos. So let's just say someone had a recent increase in their speed and that led to more suction events. It's probably the increase in speed for which the inflow cannula is sucking blood out of the left ventricle that's leading to the suction event. So sometimes what you need to do is you actually need to then decrease the speed, as we talked about over here. Arrhythmias, particularly ventricular arrhythmias, can cause suction events. This would be kind of a new pathology, right? So inflow cannula, this is kind of something, let's say after implantation, so kind of right away, right? Speed change is something we do. We change the speed. So these are kind of hints. If it's right after the implant, it could be inflow cannula position. If we have changed the speed and you get suction events, probably the speed change. These, though, are pathological things below this dotted line. Arrhythmia, hypovolemia, GI bleed, RV failure, right? These are pathologic things. So this is the patient who's had their LVAD for a year. They haven't had any speed changes. They haven't had an issue with suction events. Now they come in with suction events. These are some of the things we have to think about. So an arrhythmia, particularly a ventricular arrhythmia. Because what happens is if your ventricles aren't squeezing appropriately, right, the right ventricle is going to be unable to pump blood to the left ventricle. Right, the right ventricle pumps blood to the lungs. That blood then returns to the left atrium and goes into the left ventricle. So if you're not able to adequately pump blood from the right side of the heart into the left side of the heart, that's going to decrease the preload on the left side of the heart and lead to increase in suction events. So you'd have to address that arrhythmia. If it's a ventricular arrhythmia, you'd go down the treatment strategy pathway for ventricular arrhythmias. Hypovolemia, this is a big one. A patient comes in, they've been sick, they haven't been eating or drinking, they've been taking 3 times the dose of their diuretic, the medicine to help them pee, and they're starting to have suction events, right? Because that hypovolemia is going to decrease the amount of volume in the left ventricle, which then will increase the ability of this left ventricle to collapse as the LVAD sucks blood out of it, which then increases suction events. And obviously, treatment for hypovolemia is give volume. But we have to be careful because not all suction events are from hypovolemia, and some pathologies of suction events giving volume can be detrimental, which we'll talk about. All right. GI bleed is another one. GI bleed causes a relative hypovolemia. Now that hypovolemia is not from fluid, it's from loss of blood. And we know that patients with LVADs have a high risk of GI bleed. We talked about this in the past, right? They are on a blood thinner or anticoagulation. They often have malfunction of their von Willebrand's factor. We talked about this in that first video. Again, check it out, linked in the video description. They sometimes have platelet dysfunction or low platelets, and they're more likely to get AV malformations in their gut, right? AVMs in their gut, just because of how the LVAD doesn't do pulsatile flow the same way the heart does. So they're high risk for GI bleeds. The exact stats in that previous video, but some along the lines of like, over 25% get GI bleeds. And this can cause suction events, right? So if that patient comes in and goes, I've been having dark stools and now I'm having suction events, probably a GI bleed. Another one is RV failure, and this can be a really dangerous one. As we talked about in that previous video, many patients with LVADs end up with a right ventricular dysfunction. And the reason being, which we talked about, is that LVAD is pulling blood out of the left ventricle, and that pump is then circulating it into the aorta to then be injected into the aorta to pump blood around the body. So all that blood that the LVAD is circulating is going back to the right ventricle, right? Because all the blood from the body, inferior vena cava, IVC, inferior vena cava, superior vena cava, SVC, all that blood from the body dumps into the right atrium, and then that goes down into the right ventricle. So this LVAD helps the left ventricle because it's decompressing the left ventricle. It's sucking blood out of the left ventricle and pumping it into the aorta to be then pumped through the rest of the body. But it is all returning to the right ventricle, so it can somewhat, to a degree, can kind of quote-unquote overload the right ventricle over time and lead to right ventricular dysfunction. And a high percent of patients with LVADs end up with right ventricular dysfunction. How does that lead to suction events, though? It's as we discussed. If that right ventricle can't pump blood to the left side of the heart, right? Right ventricle pumps blood to the lungs, it returns to the left atrium, goes into the left ventricle. So if that right ventricle isn't working, then there's not going to be enough left ventricular preload because that right ventricle can't pump the blood to the left ventricle. In addition to this, what happens is the right ventricle starts to kind of dilate, and that dilation pushes that intraventricular septum more towards the left ventricle. This intraventricular septum starts to kind of bow into the left ventricle. And as we talked about, suction events are somewhat caused by this intraventricular septum bowing towards the inflow cannula, the LVAD. So if the right ventricle is dilated and if the septum is shifted more towards the left side, that septum is going to be closer to the inflow cannula, the LVAD. Now, right ventricular failure, fluids can make this worse, which is why we have to be very targeted, right? If someone's having suction events, don't just assume it's hypovolemia or GI bleed and then just give them a bunch of fluids and blood, because if it's RV failure, that will make that worse. This is where we really need to use bedside ultrasound to take a look at things. Bedside ultrasound can look at the right ventricular function. It can look at cannula position. We need these patients on telemetry monitoring to check for arrhythmias. We need to check their hemoglobin and do, if you need to, a rectal exam where you could test that stool for blood. And then bedside ultrasound can also give us a degree of volume assessment by looking at the inferior vena cava. So the summary here is that the management is very pathology dependent. Suction events can be caused by a diverse array of things. The common themes, though, are a change in cannula position, a change in speed, or anything that is going to decrease the left ventricular preload. Okay? These are things to think about and to evaluate for. The timeline for when the patient is having suction events, again, can be revealing. If it's early on, right after they got their LVAD, maybe it's related to cannula position. If it's right after they change the speed of their LVAD, maybe it's related to the speed changes. If neither of those two things are true and they're having new suction events, we have to think about all these pathologies, arrhythmia, hypovolemia, GI bleed, RV failure, among other things, as possible causes of these suction events.
Hey everybody, and welcome back to another video. Today we're going to be talking about intra-aortic balloon pumps, or IABs. These are hemodynamic augmentation devices. This is going to be somewhat of a more advanced or complex lecture for those who are more introductory to the subject. We will do our best to kind of provide adequate background as well as dive into the specifics. But if a few things are kind of above your level of understanding, feel free to ask some questions in the comments so we could try to clear things up. So intra-aortic balloon pumps. What are they? How are they inserted? What do they do? Well, it's a hemodynamic augmentation device, meaning that it assists the heart in pumping blood, and as doing such, it can help both kind of the peripheral circulation as well as the heart itself. So I want to first talk about how you insert this device. I then want to talk about how it works. We'll go into the hemodynamic results of that, and then we'll go into indications, routine care, complications, and contraindications, okay? So, inserting. So, this device is usually inserted, I don't know why that jumped over like that, usually inserted through the femoral artery. All right, the femoral artery is the artery in the groin. So what we have here is our heart, which we didn't draw, ascending aorta, aortic arch, descending aorta, into the common iliac arteries, and you insert this into one of the branches of this, the femoral artery. If you cannot insert it through the femoral artery for whatever reason, you can do a subclavian or axillary artery approach, and those are, the subclavian artery comes off the aortic arch, and then the axillary artery is near the armpit, whereas the subclavian is near the clavicle. So you can insert it through those arteries as well if you can't do a femoral approach. So what they do is they use an 8 French catheter sheath, and they insert this balloon pump up through the femoral artery into the common iliacs, into the what is the descending aorta, although we're going upwards, towards the aortic arch. And they want the distal tip of the balloon to be 1 centimeter from the left subclavian. So this here is the left subclavian artery coming off the aortic arch, and you want the tip of the balloon to be 1 centimeter from that. All right. Now, what does this do? Well, it actually is a balloon, and as a balloon, it inflates and deflates. So the goal is to inflate right after the aortic valve closes. So directly after aortic valve closure. And we'll talk about why, for those of you who are thinking about why that would happen. And then we want it to deflate, all right, right before aortic valves opens. Now think about what this would do for the blood flow out of the heart, right? Because the blood flow is out of the left ventricle past the aortic valve into the ascending aorta to the rest of the body before aortic valve opens. So what this does is it essentially augments the diastolic pressure. So why is that? To understand this, I'm going to draw an arterial line waveform, which typically looks like this. All right, and what do we have? What are the parts of this waveform? So here, this upstroke, we have the systolic upstroke. So an arterial line goes in the artery, and it measures the arterial blood pressure, and it creates a wave based on that arterial blood pressure. So the systolic upstroke is the increase in pressure that occurs in systole when that left ventricle contracts and shoots blood out of the ventricle. Okay, this portion here is the systolic downstroke, and that is, you can see obviously an elevated pressure above baseline, but the pressure is starting to decrease because systole is getting towards its end. So the pressure is starting to come down, even though you're still in systole and the left ventricle is still contracting. Less blood is coming out, and thus less pressure is being created. This here is the dicrotic notch. And let's write that out, dicrotic notch. And that is when the aortic valve closes. All right? And that's when you enter diastole, and that's what's going on here. This is the diastolic runoff, right? So after the aortic valve closes, and you get a little kind of bump in pressure because that aortic valve closes and thus increases the pressure past the aortic valve. And then after that, the left ventricle starts to expand and you get diastole, where you get this diastolic runoff. Okay, so that's a normal arterial waveform. Okay, and we'll just write that. This is an arterial waveform. So what happens then when we put in an intra-aortic balloon pump? All right, or an IABP. Well, that tracing changes a little bit. It actually starts to look like this. The systolic upstroke, dicrotic notch, then diastole, and that comes down. And that is in accordance with the waveform of the intra-aortic balloon, and we're going to go over all this, which looks like this. You get this up here, and then it plateaus down, and then deflates the rest of the way. All right? This point is inflation, which is why you get that increase in pressure. And then this point is deflation. So if we look at, and this is the intra-aortic balloon pump waveform. So if we look at the arterial tracing, all right, and we see now that you have the systolic upstroke, dicrotic notch, but instead of having, let me mute my computer there, instead of having the diastolic downstroke and systolic downstroke and diastolic runoff, you actually get a diastolic pressure that goes higher, and this is the diastolic augmentation of the balloon pump, because the balloon pump inflated, right? The balloon pump inflated, and by doing such, it plugged, you could think about it, this area of the aorta during diastole so that the pressure in the heart stayed higher, right? The pressure that you're seeing in the arterial waveform, the diastolic pressure stayed higher, all right? Because you don't get that diastolic runoff because you've plugged the aorta here. All right, I hope that makes sense. If there's questions, please ask them in the comments and we could tease it out a little bit. So you expect the arterial waveform to have diastolic augmentation in the arterial waveform tracing, and that is because the intra-aortic balloon pump, which you can see the inflation and deflation that occurs. And when deflation occurs, you get kind of this little blanch and then the rest of it runs off. So how does this change hemodynamics? That's, the question. Why are we doing this? So hemodynamic changes, and we'll do change as a triangle, delta, hemodynamic changes. Well, we could, conceptualize that the blood in the proximal aorta gets displaced during diastole when the balloon pump inflates, right? And as such, you augment, as we said, that diastolic pressure. Because the balloon inflates, plugs that proximal aorta, and increases the diastolic pressure because the balloon is inflated in the aorta. And it can do so by, as much as 30% increase. The other thing this also then does is it increases coronary perfusion. Why is this? Well, if you all remember, your coronaries get perfused in diastole, right? So your coronary arteries kind of come, right off in this aortic root, and they go to the heart. So if you're increasing your diastolic pressure and increasing the amount of pressure that we see in this aortic root, you're going to get more blood flowing in those coronaries. So you're going to increase coronary perfusion. Now, to be fair, studies are variable in terms of whether this does actually occur and by how much, but the typical teaching is you increase your coronary perfusion. All right. The other thing you're going to do is you're going to decrease your aortic volume in systole. Now let's dive into that a little bit. Right, so systole is when your heart, your left ventricle, is contracting and pumping blood out. So if you have this inflated balloon, why would you decrease your aortic volume? Well, you're actually deflating the balloon right when that aortic valve opens. And as doing such, you get this vacuum effect. And the vacuum effect actually unloads the left ventricle and decreases the left ventricle afterload. And the afterload, right, is that pressure outside the left ventricle that the left ventricle has to pump against. So you're decreasing, this balloon inflates really quickly, deflates really quickly right when that aortic valve opens and creates a vacuum effect. And as such, you're going to have more blood flow because you're decreasing the afterload secondary to that vacuum effect. and you decrease the afterload by about 20%. So you're also offloading the left ventricle. So kind of the summary of the hemodynamic changes are you increase and augment the diastolic pressure, that increases coronary perfusion pressure, and then the deflation of the balloon creates a vacuum effect that decreases afterload, thus unloading the left ventricle as well. Now, one thing to note is that the worse the left ventricle function is, so worse LV function, the less effective, so decrease effectiveness, the less effective an intra-aortic balloon pump is going to be, because you do need left ventricular function. Even if you're offloading the LV, if the LV isn't working, you're not going to have as impressive as a result from an intra-aortic balloon pump. Okay, so that's kind of the physiology of it, both from a conceptual standpoint with hemodynamic changes as well as from an arterial waveform standpoint. Let us know what thoughts, kind of questions you have in the comments, and we'll dive into indications, contraindications, routine care, and complications. Okay, so you have your intra-aortic balloon pump. What are the indications? Well, the indications, we can think of based on the function, the hemodynamic changes that occur with it. So if you have refractory myocardial ischemia, so what does that mean? That means your heart isn't getting enough coronary perfusion and you have refractory ischemia. And this is those kind of waiting for definitive therapy who have a complex, coronary disease that needs more definitive advanced therapy that might not be able to be given at that moment. You can put it in an intra-aortic balloon pump. Why? Because as we talked about, it increases coronary perfusion pressure to try to optimize that myocardial blood flow and decrease the ischemic burden. All right. Another one, which is kind of the most common, is cardiogenic shock. Cardiogenic shock is when your left ventricle, or your right ventricle for that matter, isn't pumping well enough, and it leads to hypotension and organ damage because you're not perfusing those organs. Now, this is specifically used primarily in the USA because there was a trial called the Intra-aortic Balloon Pump shock trial, and I believe it was shock 2, that showed that there was no mortality benefit at 30 days or 6 years using intra-aortic balloon pumps for cardiogenic shock. But in the USA, we still do it. All right. Another one which is related to number 1 is high-risk PCI. PCI is percutaneous coronary intervention. It's when you have clogged coronaries and had a heart attack and you have to go in and clear those coronaries out. And if you have a high-risk PCI and you're worried, because someone has a decreased left ventricle ejection fraction, so their left ventricle isn't pumping well enough, or something like severe multivessel disease, and you have to go in and fix that, and you're worried that they may not be able to tolerate the procedure, you can put in an intra-aortic balloon pump for the procedure to help bridge them while you're fixing things. All right. Another one, if you have a refractory ventricular arrhythmia, so your ventricles aren't contracting appropriately because they're not getting the appropriate electrical signal, and because of that, you're getting end organ damage. You can put an intra-aortic balloon pump to try to augment that left ventricle ejection fraction. And then the last one here is refractory heart failure. So you have really bad heart failure where your heart isn't pumping well enough. You can put an intra-aortic balloon pump to try to, augment that cardiac function until you're able to kind of get a more definitive therapy. All right. So, with high-risk PCI, I did just want to mention one more study. For high-risk PCI, there was the BCIS1 trial, it was called. And this trial showed no major adverse cardiac or cerebral events at 28 days, and there was an all-cause mortality benefit at 51 months with the intra-aortic balloon pump, which is why this is a more accepted indication rather than this one where the intra-aortic balloon pump shock 2 trial didn't show any mortality benefit. All right, so we talked about indications. What are the contraindications? So when are you not able to use this therapy? Well, that's a question. There's hard contraindications and relative contraindications. The hard contraindications are severe aortic regurg, AR. That's when your aortic valve's super leaky, and the balloon pump wouldn't be effective, right? Because when this balloon pump would inflate to augment diastolic pressure, if your aortic valve, it doesn't sit this high, but just for the sake of the picture, was leaky, all this diastolic blood flow would just regurge back into the heart and cause more damage than it was helpful. So severe AR is a contraindication. In addition to that, aortic dissection. So if your aorta has a dissection flap, so the vessel itself is damaged, you don't want to put a big balloon in there and risk aortic perforation. Another one, 4 or 3, is coagulopathy. So if someone is unable to get a significant amount of blood thinning medication, which we'll get into with routine care. 4 is severe peripheral artery disease, because putting in this device, you are going to have challenges with peripheral perfusion. You can get ischemic limbs from it. And then 5th is just sepsis, which is a systemic infection. They wouldn't recommend intra-aortic balloon pump therapy. All right. So now we'll go into routine care and then talk about complications. So routine care is, fairly, well, I shouldn't say that. There are a few things that you just have to remember to do, and if everything goes well, those things can be, fairly quote-unquote routine. You want to get daily chest x-rays. Daily chest x-rays make sure the intra-aortic balloon pump is appropriately positioned. All right. So you want to do that daily to make sure it hasn't become dislodged. And remember that positioning is 1 centimeter distal to the left subclavian. In addition to that, you want full anticoagulation, AC, with heparin, because having a foreign object in your aorta can lead to blood clotting, thrombosis, and emboli getting thrown both to the legs and to the brain. And you obviously want daily labs to monitor. All right, and then you want to be doing pulse checks to make sure the extremities are staying well perfused in the setting of the possibility for embolism, as well as the contraindication of severe peripheral artery disease. All right, last but not least, complications. The complications are related to a few different things. We can kind of divide them into certain categories. One is vascular complications. All right. Vascular complications specifically can be divided into a few different things. One is limb ischemia, so not enough blood flow to one of the limbs. This usually is secondary to inserting the intra-aortic balloon pump through the wrong artery, such as the superficial femoral artery. It can cause damage to that, and then limb ischemia. Another one is vascular laceration. So while trying to insert the device, you can actually lacerate or damage one of the arterial vessels, which can lead to a lot of bleeding. And then the third one is ischemia to the spinal cord, actually. So if you, block off some of these spinal arteries from the aorta, you can lead to spinal cord ischemia. And then you can also get ischemia to the mesentery, or the gut, for the same reasons. All right. This usually occurs in 6 to 25% of cases. So it's, unfortunately fairly common. And then the other grouping are just other complications. And these take root in a few different categories. One, you can get cholesterol emboli. So cholesterol is obviously a fat, and it coats arteries, it's part of peripheral artery disease, and you can dislodge that and shoot little showers of cholesterol emboli throughout the arterial system, into the fingers, extremities, brain, etc. And you often will see thrombocytopenia, which is low platelet count, livedo reticularis, which is a skin finding, kind of a web-like rash pattern on the skin, and then eosinophilia. You usually have increased eosinophils, and believe it or not, you actually want to stop the anticoagulation if you start to suspect cholesterol emboli, as it can exacerbate things. All right, another thing here, you can get strokes, cerebrovascular accidents. If you dislodge a thrombus while inserting the intra-aortic balloon pump, it can actually shoot up into the brain and cause a stroke. Another one is sepsis, right, which is a systemic infection in the body, especially if it's in place for more than 7 days. All right. And then the last category is kind of a smorgasbord of things. You can get hemolysis, which is lysis of red blood cells, given that there's a device in the bloodstream. You can get thrombocytopenia, which is low platelets, as they're consumed, as again, there's a foreign cytopenia, foreign object in the bloodstream. And then you can also get skin infections in the area where it's inserted in the groin because, you have something that continually is coming out of the vessel in the groin and it's kind of an opening into the body. Or extracorporeal membrane oxygenation. Now, depending on when you view this video, it was actually recorded during the COVID-19 pandemic when, as a channel, we were coming out with a lot of COVID-19 related content. Now, ECMO is relevant to COVID-19 because actually severe end-stage acute respiratory distress syndrome from COVID-19, some of those patients have been placed on ECMO. But in today's video, we're going to be discussing ECMO in general. So it's going to be an introduction to the principles of ECMO. We're going to talk about what ECMO is, how it works, some different types of ECMO, including venous and venous arterial ECMO, the different parts of the ECMO circuit, so the machine, how the machine functions, what are the parts of the machine, what can you manipulate to optimize the ECMO circuit, we'd call it. We're going to then talk about indications to put a patient on ECMO, contraindications to putting them on ECMO and why, and then complications, because unfortunately with ECMO there are a number of really, really severe complications. And we're going to use some pictures and diagrams and stuff to go over this. So to start with the general principle of ECMO, ECMO in general is a therapy for when the lungs and or the heart are simply not working. So you're not able to oxygenate your blood or get rid of carbon dioxide, or the heart is unable to pump enough to provide enough blood flow to the organs. So what you do is you hook the patient up to ECMO, which is essentially a machine, and you pull blood out of the body, put oxygen into that blood and take carbon dioxide out of that blood, and then pump that blood back into the body. And we put here, seems straightforward, right? It's just a circuit. You take blood out, you oxygenate it, take carbon dioxide, and then you pump it back in. But unfortunately, it is tremendously complex and wrought with, complications. Make no mistake, this is a therapy for patients that have absolutely no other option. Patients that are going to, die without something more significant such as ECMO to support them while their body heals. This is not a definitive therapy, meaning it's not for someone that has no potential to heal. This is a, intervention that is meant to temporize and keep someone alive while their lungs and or heart heal enough to then maintain on their own without the ECMO circuit. All right. So what are kind of the two main different types of ECMO? Well, there's venous-venous ECMO, also known as VV ECMO, and there's veno-arterial ECMO, also known as VA ECMO. And we're going to get into why they're called these two different things and how they differ. Let's start over here with venous-venous. So in venous-venous ECMO, the idea is you're taking blood out of the IVC. The IVC is the inferior vena cava, or the right atrium, the RA, and then you're returning it back to the right atrial circulation. This is, let us mute our computer, apologies. This is primarily for respiratory failure. So let's go into a diagram to better understand this. So here is the body, right? We have an arm here, we have an arm here, we have the two legs, right? Leg here, leg here. And what we're seeing is the circulation. So this blue tube here is the inferior vena cava. This red tube here is the aorta. We're using these two different colors to decipher what is a vein and what is an artery. So the blue are veins, and the red are then arteries. Okay? So what we have down here, when the aorta branches, or the two branches going in the IVC, what we have are the femoral vessels. So we have femoral arteries and veins, right? And in the red you have the artery, and in the blue you have the vein. So in venous-venous ECMO, you're taking blood from a vein and putting it back into another vein, hence venous venous. So what you're doing often is you're pulling blood out of one femoral vein, right? So this is the cannula. This is a huge, think of it as a large needle that's suctioning blood out of this vein. So the blood comes out of this femoral vein and then into the ECMO circuit, right? And it's deoxygenated blood. So it's blood that, has traveled through the body already and was on its way back to the heart to get pumped into the lungs and get oxygenated. So it's deoxygenated blood. It then goes through the ECMO circuit, it gets oxygenated, and then so now it's red, right, because it's oxygenated, and it gets pumped back into the femoral vein at this point for venous venous, right, because it's going from one vein to another vein. It gets pumped back into the femoral vein, up into the IVC, and it's delivered to the right atrium of the heart. And then that blood goes from the right atrium to the right ventricle and gets pumped out into the lungs. The lungs then bring that blood back to the left side of the heart, where that oxygenated blood is pumped into the circulation through the aorta into the arteries and delivers oxygen to the body. So venous venous ECMO, right, is for respiratory failure primarily. Why does that make sense? Well, what we're doing is we are delivering blood to the right side of the heart. We are not bypassing the heart in general, because that blood on the right side of the heart has to get pumped to the lungs, then back to the left side of the heart, which then pumps that blood to the body. So all we are doing is oxygenating that blood. The heart is doing work just fine. It's pumping that oxygenated blood throughout the body. It's the lungs that are not functioning. So we are delivering oxygenated blood to the right side of the heart. So typically what we would see, right, is that the right side of the heart has deoxygenated blue blood. But in ECMO's case, VV ECMO's case, you're delivering oxygenated blood to the right side of the heart. That blood then does get pumped through the lungs, but the lungs aren't working, so the lungs don't contribute too much. And then that blood returns to the left side of the heart and is pumped to the body. So what you can think here is, this cannula that is delivering, right, we scroll back down, right, we're pulling blood out of the femoral vein, it's getting oxygenated in the ECMO circuit, it's getting pumped back into the other femoral vein, into the IVC to the right side of the heart. This blood is actually oxygenated after it comes back out of the ECMO cannula to the right side of the heart. Does that make sense? So I don't want to belabor the point, but if we just draw, a heart here, I'm not an artiste, but what we have is right atrium, right ventricle, left atrium, left ventricle. And as we know, deoxygenated blood from the body comes to the right atrium, goes into the right ventricle, then gets pumped from the right ventricle out into the lungs, which will, say, look like this. The lungs then oxygenate that blood and pump it back to the left atrium, which that oxygenated blood goes into the left ventricle, and then the left ventricle pumps it out to the body. So with the VV ECMO circuit, what we are doing is what is typically deoxygenated blood, we'll do DO here, on the right side of the heart, is actually oxygenated blood, because the ECMO circuit is delivering oxygenated blood to the right atrium, which is then being pumped through the lungs, back to the left side, back to the body. All right. If that doesn't make sense, let us know in the let us know in the comments, and we can, discuss it further. And we usually use, as we talked about, the femoral veins on both sides, but you could use the jugular vein, which is a vein in the neck that also travels down to the heart. All right, so that's VV ECMO, venous venous ECMO. It's meant as a surrogate for respiratory failure when the lungs aren't working, such as in acute respiratory distress syndrome, which, just for a timely correlate, COVID-19, we've seen a lot of really severe acute respiratory distress syndrome. Veno-arterial ECMO, or VA ECMO, also takes blood from the inferior vena cava, or the right atrium, but instead of returning it to the femoral vein, it returns it to the femoral artery. And this bypasses both the heart and the lung function, and its primary role beyond that of respiratory support is actually for hemodynamic failure, or, cardiac failure. If your heart is not pumping, the ECMO circuit will take the blood oxygenated and pump it back in. Unlike for VV ECMO, where you're going vein to vein, in VA ECMO, you're going vein to artery, right? So you often are taking it from the femoral vein and pumping it into the femoral artery. So if we go back down to our picture, if we look over here, right, one cannula from vein and then the other cannula into vein. Here, though, we're taking it from the femoral vein, sucking this deoxygenated blood out. It gets oxygenated in the ECMO circuit, and it gets pumped back into the femoral artery, right, red instead of vein. And this then goes into the retrograde flow back to the heart, which we'll talk about a little bit more in a second. But what you can see is that VA ECMO is appropriately labeled because it goes from vein to artery, whereas VV ECMO goes from vein to vein. And if you think about going from vein to artery, what you are doing is you're essentially bypassing the heart, because you're taking blood out of this vein and then you're pumping that oxygenated blood into the aorta to then be distributed to the whole body. And the heart function itself is, there's a lot of caveats here. The heart function itself is very important, even in VA ECMO, but the heart function itself in general is less important because you're giving the aorta, which is the big blood vessel that delivers blood to the whole body, oxygenated blood and bypassing the heart. All right, does that make sense? Again, let us know if it doesn't in the comments and we can go over it in more detail and answer your questions. So what is the ECMO circuit itself? What makes it up? What does it need to function? Well, if you think about its roles, you need a pump to pump the blood, a gas exchanger to take the carbon dioxide out and take the carbon dioxide out and put the oxygen in, and then you need to keep it warm. So it is a simplistic conceptual setup, but it's tremendously complex at its roots. So the first portion is you have a centrifugal pump. Centrifugal meaning that the pump spins, and the spinning creates a vortex that pulls blood in and then pumps the blood out. And as a vortex, right, it's spinning, it's measured and set at RPMs, RPMs being revolutions per minute. And that makes sense, right? When you think about RPMs, in cars or really anything circular that spins, revolutions per minute. And those revolutions per minute equate to the liters per minute of blood that is going to be pumped through the ECMO circuit back into the body. So if you have higher revolutions per minute, the pump is spinning faster, you're going to deliver a higher amount of blood back to the body, so you have higher liters per minute of blood delivered. The challenge with that is that this vortex that's sucking blood in and spinning in a circle actually shears red blood cells and leads to hemolysis. So the higher the RPMs, the better flow, but also the more hemolysis you get. All right? ECMO circuits, there's some variability, but they typically can deliver anywhere from, 1 to 6 liters per minute. The contrary to, increasing the liters per minute with increased hemolysis, if you decrease the RPMs too low, which leads to too low of liters per minute blood flow, we're just going to move past that, you actually are going to get an increase in blood clotting because that blood will be too stagnant in the ECMO circuit itself. So what you want to do is titrate your RPMs to the appropriate liters per minute depending on the pathophysiologic problem, with the caveat being higher RPMs are going to have more hemolysis and lower RPMs are going to increase your risk for blood clotting in the ECMO circuit, which we'll go into more detail in a little bit. Okay, there's also, we didn't put this in here, but there's also what would be called a roller pump. The roller pump is just meant to compress the tubing, right? There's tubing that connects to the actual centrifugal pump, but that's less, it's all important, but it's less relevant in terms of things to look for and manipulate. Okay, it also has a gas exchange membrane or a gas exchanger. This is important, right? Because as we talked about, venous ECMO is all about respiratory failure. You need to oxygenate the blood and pull out carbon dioxide, whereas veno-arterial ECMO is about respiratory failure sometimes, but is primarily about the pumping. So the pump is most important for veno-arterial, whereas the oxygen gas exchange membrane is very important for venous-venous. So this is a silicone membrane, and this is a format, a depiction of it. So what happens is the blood gets pumped through this membrane, and the other portion of the membrane, you're sweeping gas through it, and that gas sweeping through it is full of oxygen. So the oxygen diffuses into the blood, whereas the carbon dioxide diffuses out of the blood. Then the sweep expels the carbon dioxide, and what is left is, oxygenated blood. You can control how much FiO2, the fraction of oxygen that you are sweeping past the membrane. So for people who need more oxygen support, you can make, this 100% oxygen. For people that need less oxygen support, because you don't want them to be oxygen toxic, you could set it wherever you want, 80%, 60%, etc. The FiO2 that you set controls the oxygen content, but it is the sweep speed, how fast this is sweeping through the membrane, that controls the amount of carbon dioxide that comes off the blood. So if you have hypercapnia, too much carbon dioxide in the blood, you want to increase the sweep speed, because that will it'll increase the amount of carbon dioxide that it's sucking or diffusing out of the blood, and thus decrease the amount of carbon dioxide in the blood. So increase the sweep speed if you have too much carbon dioxide, whereas you'll increase the oxygen concentration in the gas itself if you have too low of oxygen. All right, and the last thing, which is a smaller thing, is the heat exchanger. This is a circuit that goes outside of the body, and you want to make sure that that blood stays warm before you return it to the body. So typically it's set at 37 to 40 degrees Celsius, depending on the patient's temperature. Just of note, if you set it too high, higher temperatures actually lead to hemolysis, or those lysing, or that lysing of the red blood cells. All right, so then next is indications and contraindications. This is somewhat of a gray area, or a challenging area in terms of the indications. So we're going to focus on VV ECMO indications. VA ECMO indications are related to, cardiac and hemodynamic failure, whereas VV ECMO indications are related to respiratory failure. People have put forth some kind of numerical, indication numbers, but these are not, not followed absolute. So there's some subjectivity to deciding who, is a candidate for and should require ECMO. But in general, you can think of it this way. This is a helpful guide. Individuals who you anticipate having a high mortality, greater than 50%, their PaO2 to Fi2 ratio is less than 150 on a fraction of inspired oxygen, and greater than 90%. So what does that mean? So the PaO2 to FiO2 ratio is how much O2 is in the blood compared to how much O2 you're giving the patient. So lower means that that patient is on a high amount of oxygen you're giving them with a low amount of oxygen in their blood. So lower is bad because it means they're requiring high oxygen support and still not oxygenating well in their blood. And they go to say that this is despite 6 hours of optimal care. So you want to make sure these patients are on, appropriate ventilator settings and all that. And if even with 6 hours of optimal care, they still fulfill these requirements, they'd be, a possible candidate for ECMO. You also can start ECMO for hypercapnic respiratory failure. Increased CO2 is hypercapnia. CO2 actually causes the blood to be more acidic. It causes a respiratory acidosis. So if you're acidemic and your pH is less than 7.15, despite optimal care, with this hypoxia, you may be a candidate. And then age less than 65 years old. And again, these are, not totally hard and fast rules. Each institution kind of has their own set of rules, but this is just somewhat of a rough qualifier to get an idea of who would be a candidate for VV ECMO. All right. Contraindications would be life expectancy. ECMO is invasive. There are lots of complications. If the patient, even with ECMO, does not have a possibility of recovering, then they shouldn't be started on ECMO. Again, it's not definitive therapy. It's meant as a bridge while a patient heals. And when we say heals, we mean, heals over days, not months or years. Another contraindication is severe aortic regurgitation. So why would that be? Well, if we go up, and some of these contraindications, so this is VV and VA ECMO. So if we go up and look at VA ECMO, veno-arterial ECMO, right, which is this right column here, you are shooting up retrograde blood flow. And we're going to scroll down to a different picture to go over that in detail. So what happens in VA ECMO, and let's zoom out a little bit so we can see a little better, is you have, as we've talked about, the femoral arteries. So this is femoral artery on one side, femoral artery on another side, and this is not a perfect drawing. But what's happening is you're drawing blood out on one side, pumping it through the circuit, and then pumping it into the femoral artery on the other side. So what is happening is you actually are shooting that blood retrograde back up the aorta towards the heart. And as such, the blood perfuses, all these different blood vessels and organs that come off the aorta. Now, the part of the heart that aorta enters into is through the aortic valve, right? So we'll just kind of draw a rough drawing here. So this is the aorta, and then here is the left ventricle with the left atrium. So what we have is the mitral valve. Blood flows through the mitral valve into the left ventricle, and then we have the aortic valve, and it flows out of the aortic valve into the aorta. But in ECMO, VA ECMO, you're getting a retrograde blood up into the aorta. So if you have really bad aortic regurgitation and these valves aren't working, what will happen is that you'll just get really bad retrograde blood flow into the heart, and it'll meet with this forward flow, and you'll get cardiac thrombus and essentially cause more heart damage than help. And that turned out to be a really sloppy drawing, but hopefully that was helpful. If that was confusing again, just ask us in the comments and we can answer any specific questions or go over it again. All right. In addition to that, aortic dissection is a contraindication. Reason being, as we've kind of just alluded to, if the aorta has a dissection in it and you put a cannula going towards the aorta and shooting blood up there, it's going to cause a worsening dissection. And what an aortic dissection is, for those of you that don't know, is, so here is our aorta. It's this big blood vessel. The blood vessel has these walls, and if a wall is dissected, it forms this flap. And if you have an aortic dissection, this is part of the wall that has dissected off the other part of the wall. And you're high risk for this bleeding and perforation of the aorta. And if that happens, you will die. So an aortic dissection is another contraindication. And then there's some other ones here that make intuitive sense. So an ANC less than 500. ANC is your absolute neutrophil count. These are immune cells. If you are putting foreign objects into the body, such as the cannulas that you need to for ECMO, you're high risk for infection. So if you're immunocompromised and your absolute neutrophil count is less than 500, you shouldn't be on ECMO because you're most likely going to get an infection and probably die from that infection. If you have a contraindication to anticoagulation, I could have spelled some of that out, but CI is contraindication to AC is anticoagulation. We'll get into it, but you have to be anticoagulated to be on ECMO, or else you'll get blood clots everywhere. So if you can't be anticoagulated, because let's say you have a really bad GI bleed or a brain bleed or something else, you can't be put on ECMO because the anticoagulation will make that bleeding worse, and you'll die from results of bleeding. And then last would be central nervous system damage or brain damage. Is another contraindication. All right, so let's see. So far we have gone over the general principles, venous-venous versus venous-arterial, how it's set up, and then the parts and machines that make up the ECMO circuit, as well as indications and contraindications. Next is maintenance. How do we maintain the ECMO circuit? So you have now decided that the patient does have an indication. They didn't have contraindications. They were cannulated, meaning you placed the catheters, and they're on the ECMO circuit. What do you need to do now? Well, you need to monitor their venous oximetry. What's that? So we have, right, arteries and veins, as we've talked about. Oh, that didn't show up. We have arteries and veins, and the venous oximetry is the O2 concentration. I do brackets for O2 concentration in the veins. And again, it's not as simple as this, but that's a good way to think about it. And if the venous oximetry is low, you want to be careful because it is a suggestion that your ECMO circuit, you need to, adjust how well it's delivering oxygen. All right. In addition to that, as we've talked about, you need to anticoagulate these patients with heparin. Heparin, right, is a medication that we often use for both treatment and prevention of blood clotting. All right. It is a common medication, but the dosing you need to use in ECMO is quite high. As you can tell, patients on an ECMO circuit, and we're going to scroll up to go back here, you're pulling blood out of the body and putting it through this circuit. This is very high risk to be very prothrombotic and cause blood clots to form, right? Because anytime you're taking the blood out and putting it in a foreign material and changing how that blood is flowing, that blood often gets stasis and it will clot very, very easily. So you need to have these patients on anticoagulation with heparin constantly. They are also very high risk to bleed. So the other thing is you want to maintain their platelets above 50,000. So on the ECMO circuit, you are going to consume platelets, right? You're, having small amount of lysis of red blood cells, you're having small blood clotting events. The ECMO circuit itself is going to consume platelets. And if those platelets drop too low, platelets are involved in blood clotting and you can have more bleeding events. You want to check platelets and make sure to maintain platelets above 50,000. They also, some sources say maintain hemoglobin greater than 12. In our experience, this is not part of our protocol necessarily, so we kind of put a question mark here, but some sources will advocate to keep the hemoglobin above 12. And then the other thing is reduce your ventilator settings. These patients are often intubated on ventilators. The ECMO circuit is going to oxygenate the blood and take out carbon dioxide. So that vent the patient on doesn't have to be on huge settings. And as we know, vents can cause trauma to the lungs through pressure. It can cause trauma through the lungs through volume and cause oxygen toxicity. So reduce those ventilator settings to what we, would consider minimal ventilatory support. Oh, I don't know why that didn't draw either. We'll erase that and we will place it over here, minimal vent support. All right. Okay. And then last but not least, the complications. Lots and lots of potential complications. So as we've mentioned, a big complication is bleeding. 30 to 50% of patients on ECMO will bleed. And that's secondary to the anticoagulation, the heparin that they have to be on, as well as their thrombocytopenia or low platelets that we talked about. And, our clinical experience, many patients on ECMO bleed. Now, sometimes that's just oozing from the cannula sites that are going into the groins, into the femoral vessels. Sometimes that is more significant bleeding in the brain or the GI tract, but many of these patients have bleeding problems. Interestingly, they also have thromboembolic problems or blood clotting problems. Many of them get DVTs or deep vein thromboses, pulmonary embolisms or blood clots in the lungs. And this is because of the fact you're on the ECMO circuit, and that's a foreign body. It's a foreign body. You're taking blood out of the body into this circuit, and that leads to blood clotting. A way you can monitor this is always look in the ECMO circuit itself for signs of blood clot, and that would suggest if there are signs of blood clot that patient is most likely going to have a blood clotting event. There's a lot of neurologic complications. You can have encephalopathy or confusion. You can have strokes from, the blood clotting that gets shot up into the brain, and even brain death. There's cannulation-related complications as well. So cannulation is when you actually place the cannulas into the femoral artery. So we'll scroll back up to that picture. This is the groin, right? And cannulation is when you're actually placing these big cannulas in the blood vessels. And they're big cannulas, 23 to 29 French often, which is a big caliber cannula. And you can perforate the vessels you're trying to place them in. You can dissect those vessels, and you can cause ischemia as well by clotting off the lower legs. So there's a lot of cannulation-related potential complications as well. Not necessarily specific to ECMO, but you can get heparin-induced thrombocytopenia. We actually talked about this in a previous video. We will link it in the video description. Heparin-induced thrombocytopenia is when your body actually forms an immune response to heparin that leads to some potential blood clotting events. And in this case, if it happens on ECMO, since you have to be anticoagulated with heparin being the preferred choice, you'll switch that patient to argatroban, which is another blood thinner. A few other things. You can get pulmonary hemorrhage. This is pulmonary being lung, hemorrhage being bleeding, so hemorrhage in the lung. The reason being is you can have poor LV. LV is left ventricular emptying. So what does this mean? So think about the ECMO circuit for a second, and we'll scroll back up to the pictures. As we said, the ECMO circuit pumps a bunch of blood into the heart, and then that goes through the lungs to the left side of the heart. Well, if the left side of the heart is not working well, and you're forcefully pumping all of this blood into the lung, but then that blood in the lung is not being emptied by the left side of the heart well enough, you're going to get a bunch of venous and arterial engorgement in the blood vessels in the lung, because that ECMO circuit is still pumping. Whether it's emptying well on the left side or not, you're still getting all this volume pumped into the lung. So if you're having, a bunch of volume, 3 arrows pumped into the lung, which we'll draw again here, yay, lung, and then just 1 arrow pumped out of the lung because the left side of the heart is not working well, you're going to get all this blood that gets engorged in the lung and can lead to pulmonary hemorrhage. All right. In addition to that, you can get cardiac thrombosis. We talked about this with the retrograde flow, right? The VA ECMO, you're taking blood out of the femoral artery on one side into the ECMO circuit and pumping it into the femoral artery on the other side to retrograde flow up the aorta towards the heart. And if the heart isn't pumping well, that blood can pool in the heart and lead to cardiac thrombosis or blood clot in the heart, which is obviously bad. And then you can also get coronary and cerebral hypoxia. This is an idea that is commonly called north-south syndrome, and it is, we can use this drawing. So the heart here, with its native function, is pumping blood this way, whereas the ECMO circuit is pumping blood retrograde back up to the aorta. And depending on how well the heart is working, at some point you may get pooling somewhere in here. So if the heart isn't working well, this retrograde blood that's oxygenated from the ECMO circuit can travel all the way up the aorta, go out of the vessels. These go to the body, go out of these vessels. Some of these vessels go to the brain, and then get to the heart and perfuse the heart. But if you start to regain some native function in the heart, but the lungs aren't working, and your heart is going to pump blood to, let's say, here, whereas the ECMO circuit only pumps blood to here, and this is where you kind of get the pooling, you are going to get the deoxygenated blood that the heart is pumping that is then going to travel to both the heart as well as the brain. And we can, erase this here. Let's just say it travels to here as well as the brain, and you can get cerebral ischemia. North-south syndrome. The heart has regained enough function to pump some deoxygenated blood to then mix with the ECMO blood, and some of that deoxygenated blood then goes to the coronary and cerebral circulation. We say sample blood from the right upper extremity to figure this out, because this blood vessel closest to the heart is going to go to the right upper extremity. And if this right upper extremity shows that this blood is deoxygenated, it's an implication that it's coming from blood from the heart rather than from the ECMO circuit, and that you could be getting hypoxia that's in the coronary cerebral circulation. Another confusing topic, and one that we'll probably do a separate video on in general, north-south syndrome. So that is all we had for kind of our introduction to ECMO. Tremendously complex, tremendously interesting though, and we think we'll probably make a number of kind of small spin-off videos going into more detail on each one of these things in the future. So thanks for checking out the video. We hope it was helpful and informative. Let us know what thoughts, comments, questions you have down below. If you enjoyed the video, give us a like. We have, let's see, we've been doing a ton of COVID-19 videos lately, but we do have some, general medical videos out there on heparin-induced thrombocytopenia. We did a video on intra-aortic balloon pumps that has gained quite a bit of following. So we'll link some of that in this video's description. Check those out and check our page out. We'll hopefully be getting back to more general medical education content with the, optimistic view that the COVID-19 pandemic will hopefully be improving and eventually be...
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.